Welcome everyone to today's presentation on integrating mental health into ART adherence services. The presenter is Amaechi Okafor from Nigeria. Problem statement. Achieving high rates of ART adherence is a serious challenge for HIV treatment programs in Nigeria. Approximately 20 million Nigerians suffer from mental illnesses, and the prevalence of depression among people living with HIV was 23.1%. This figure is slightly higher than the figure reported in the general population. Depression among people living with HIV negatively affects their adherence to ART, which equally leads to poor retention. 46.7% of the total population that are depressed were mildly depressed, 50% were moderately depressed, 3.3% were severely depressed, while 40% were within the age range of 30 to 39. Appropriate mental health interventions reduce the negative impact of mental health disorders and depression. The project overview. MSH implements the USAID-funded care and treatment for sustained support, otherwise known as the CAS project, which runs from 2016 to 2018, to support the maintenance and the uninterrupted delivery of quality HIV/AIDS and TB care and treatment services integrated into Nigeria's health system. The CAT project operates in 41 comprehensive health facilities and 87 PMTCT sites in 5 states of Nigeria. The states are Sokoto, Kebbi, Zamfara, Niger, and Kwara. Our strategic approach. CAT project collaborated with Gede Foundation to facilitate the integration of mental health services into ART adherence services to create a one-stop shop for clients. To facilitate implementation of this integrated model of mental health care for people living with HIV, the CAT project trained service providers on recognizing signs of mental disorders. Service providers were equally trained on appropriate counseling information for clients. Then we adapted screening tools for use by service providers. We equally created referral networks to link clients to mental health services, and we also trained adherence counselors to screen and identify patients with common or primary symptoms of mental disorders while providing adherence counseling services. Implementation. First of all, we mapped out supported facilities and skilled staff who can provide mental health services to people living with HIV. Then, various levels and stages of capacity building sessions were facilitated for these select service providers. The service providers screen clients, provide counseling, and as needed, escort suspects directly to the psychiatric clinic instead of giving them referral forms to go on their own. Facilities without psychiatric facilities make referrals to other facilities where psychiatric services could be obtained. Then, adherence counselors are an ongoing link between ART and psychiatric clinic, facilitating communication, documentation, and follow-up. Then, the sample of a screening form. The screening form we adopted for screening mental health disorders among people living with HIV has some basic information with the basic requirements. Some issues like the facility name, the date of visit, the name of the client, the state code, the facility number, the enrollment number, and so on are the information contained in the assessment form. During screening, clients were taken through different sections, which has to do with general appearance, the memory, concentration, the speech, the focus, and then some other areas through which we can indicate if someone has the symptoms of mental disorder. So if a client answers to 5 of the screening questions, that leads us to suspect that the client may have mental disorders. Then we refer for further psychiatric evaluation. Then the results of our intervention. 70 personnel have been trained on integrating mental health with ART adherence services. Out of these 70, 55 were service providers based at the health facilities, 10 were MSS staff, while 5 are government of Nigeria counterparts. Then 319 clients have been screened between August and October 2017, and 87% of the total population screened are women. Out of these 319 that were screened, 56 were identified with mental health related disorders, and this represents 17% of the total number screened. Out of this, 89% were women. Then 38 of the total number that were identified were referred for treatment, and they completed their treatment. 86% of those who were treated were women. The lessons and implications from the intervention. With this integrated approach, clients receive multiple services in one clinic visit. A client who comes for a normal drug refill or for adherence counseling or PDP services uses the opportunity to access mental health services as well. Instead of going home and coming another day, the same clinic day is used to provide multiple services in one visit. So this saves time and the cost for the client. The number of times the client is supposed to go and come back for different services were integrated into one, and the equally saves cost for the client. The cost of transporting to and from the health facility is reduced to one visit, and that one visit is used to provide different services to the client. Not all mental disorders require medication. Proper counseling is key. There are some clients that require only counseling. Early stakeholders engagement is crucial to successful service integration. Before starting the services, it's key to engage government counterparts, the Ministry of Health, and the other line ministries that may be necessary. Then the service providers at the health facilities, equally people living with HIV in their support groups to make them know that these services are available for their members to benefit from. Then the head of health facilities. The combination of this ensures a successful service integration. Education and awareness is key to the reduction of stigma and discrimination associated with mental health disorders. The service providers were educated and sensitized on the importance of reducing stigma and discrimination against people living with HIV who are equally living with mental health disorders, because it amounts to double stigma for them, dealing with the issues of stigma that has to do with HIV, and then added another stigma and discrimination that has to do with issues of mental health disorders. Thank you for listening to this presentation. I hold on for your questions and contributions.